So today we have our LMUterus model. This is a model that's designed to allow us to practice the surgical skills that we may choose to use in a spay. I'm going to go through and show you one method for performing a spay on the LMUterus model. I do want to make note that this is not a recipe for a spay in a dog. It is not a recipe for a spay in a cat. However, in the process of demonstrating these, you will obtain all the skills that you need and then can use in your dog or cat spays. But again, this is not necessarily the way that I would spay a live animal. So I'm going to start by making my incision. And as I'm going to make my incision, it's probably going to be a little bit of a longer incision because a spay incision tends to be a little bit on the longer side as opposed to just a real short stab incision. And so I have two grips on my scalpel handle. One is the slide grip. This is for longer incisions. This one's going to be appropriate for my spay incision. The other is a pencil grip. This is for shorter incisions, and so this is one that I'm going to choose to use perhaps for some other things today. So as I go ahead and put the scalpel handle in my slide grip, I'm going to stretch the skin perpendicular to where I'm making my cut. Now my goal is on my initial pass of the scalpel handle and the scalpel blade is to cut through the entire thickness of the skin, but not really to go much farther than that. So I'm going to go ahead and make my skin incision, again stretching perpendicular and trying to go through the skin in one cut. And so in this particular LMUterus model, you'll see that the skin is a flesh tone silicone and that the inner layer is foam. And in this particular model, the foam is blue. And then in the middle, there'll be a little bit of a mesh. And so you can kind of see the mesh peeking out there. And that's still part of the sub-Q. And there's actually another layer of blue foam underneath that still is sub-Q before I get to body wall. So at this point in my patient, I would have concluded that I'm not down to the body wall yet, and so I would want to gently use some sharp dissection to reach that body wall. And in the LMUterus model, that body wall is red, so I am going to know when I reach it. So I'm going to be a little bit more tentative about my cuts here because I don't want to prematurely enter the abdominal cavity. And when I start to see that red body wall peeking up at me, and there you can see I can just start to see it, I'm not going to take real deep bites at that point. I'm just trying to clear it off so that I can see. And so what you'll see here along the cut layers is that the flesh tone is the skin, the sub-Q again is the blue foam, the mesh, and more blue foam, and you can see now that I'm down to abdominal musculature or body wall, which is indicated by red silicone. This model does not have a linea alba, so in other words, this incision would mimic what you would find in a paramedian incision, which means we're going to be cutting through abdominal wall musculature. That's not an ideal situation in our live patients who have a linea alba. In those patients, we would go to effort to find the linea and to incise through it, which means we would not be incising through abdominal wall musculature. At this point, we are ready to go ahead and enter the abdomen, and so the way that we're going to do that is grasp with thumb forceps to pick up the body wall while we make a stab incision into the abdomen. Now naturally, this is a time when we want to make sure we don't hit any organs that are in the abdomen, and so we want to be a little bit careful. And then we're going to choose to extend our incision, either using a scalpel blade or by using scissors. Now when I'm deciding which to use, I actually need to decide before I make my stab incision. If I'm going to choose to make my stab, or if I'm going to choose to extend with a blade, I should make my stab incision at the cranial portion of the abdomen. This LMUterus's head is this direction, its feet are this way towards my instrument table, as would be the norm. If I wanted to extend with scissors, I would make my stab incision at the caudal end of the incision. And the reason for that is I use cutting instruments in my dominant hand, and so that means the hand that's closer to my instrument table. I am a right-handed surgeon. So if I had made a stab incision at the caudal end of the incision, then I could go ahead and extend with my scissors. On the other hand, if I wanted to extend with my scalpel blade, I again would keep it in my dominant hand. I would need an incision at the cranial portion of the patient so that when I could cut from cranial to caudal. Because cutting with a scalpel blade may be slightly more challenging, I'm going to go ahead and demonstrate that method. If you were to choose to extend with the scissors, the thing to remember is that we cut in the middle portion of the scissors. We don't snip them all the way closed because that tends to create a jagged edge, and we just glide them right along the linea while we're picking up gently from the body. That way we don't stab internal organs. And you'll notice that I selected blunt tip scissors. We wouldn't want to use sharp tip scissors. So in my live patient, I'll find that I can pick up the body wall pretty well, particularly if I have Atson forceps, and you'll see I just have brown Atsons today, so I'm not going to have that benefit. But in my live patient, I may switch to Atsons here, and that gives me a better grasp of the body wall. In the LMUterus model, I can't lift up very far before I start to have problems with my forceps breaking away from the foam. And so what I'm going to do is I'm just going to demonstrate lifting up slightly while I make my stab incision, understanding that in my live patient I would pick up farther than this. And then I'm going to do a reverse stab incision, so that means a pencil grip on my blade with the blade facing away from me, and I'm going to pass the blade near to where I've pulled up through the body wall, and I want to enter the abdomen. And so sometimes it's difficult to tell if you've entered the abdomen or not, and the easiest way to tell that is to try carefully to put your forceps down in the abdomen. And if you're able to get the forceps down in the abdomen, then you know that you have in fact gone in deep enough. And if you're not, then you may need to make a second stab incision. And if you were to do that, then you're going to pick up again and try to make a stab incision in, roughly speaking, the same location you made the first one. Whenever you think you're through to the abdomen, you can go ahead and put your thumb forceps into the abdomen, and you're going to pick up away from the patient. And we're picking up away from the patient so that we're not near internal organs that we don't want to damage. And then we're going to use our forceps as basically as a protector for my blade. And so what that looks like is, as I'm going down the patient, my blade is never lower than my thumb forceps are. And so I'm going to pass the thumb forceps down and move the blade along with it. I want to be careful to keep the blade flat as opposed to pointed inward. You can see that that could potentially target those organs as well. So I go ahead and put my thumb forceps in and pick up. And at this point, I'm having my assistant kind of stabilize the base of the LMUterus model, because as I move the thumb forceps and scalpel down, the model tends to want to move just a little bit. And so then I'm going to gently extend that incision. And my goal is to extend it all the way to the caudal portion of the incision. And so we're going to double check and make sure that I made it that far. And it looks like I could go a little bit farther, and what I'm seeing is that my skin incision ends here, but my abdominal incision doesn't end until here. So if I'm going to make this large of a skin incision in my patient, I'd at least like to have the benefit of having that large of a an incision in the abdominal wall so that I can operate in it. So I'm just going to go ahead and finish up. And most people will make that abdominal wall incision just a little bit shorter than they'll make their skin incision. That way when they're closing, it's easier for them to see those body wall sutures, although you'll see some variation in technique there. So looking at this now cut edge sideways, you're going to see again skin. You've got sub-Q with a mesh layer in there that helps it not to pull through in your suturing, and body wall. At this point, my assistant's going to go ahead and pull out the incision stick that's there so that our patient doesn't sort of have their abdomen dip down in. And so this is going to give me access to the abdominal cavity. Now, there's not a lot exciting in there in the LMUterus, but there is actually, as the name implies, a uterus. So I'm going to reach in there and find that. And we're not using a spay hook here because without abdominal contents, it's not actually very accurate in the way that you choose to use it. But I'm going to reach down in and I'm going to pull out a uterine horn. So to start, I'm going to pull out the uterus here and show you what the parts are, even though when you're spaying your animal, probably the only thing you'd pull out to start would just be one uterine horn. But in this case, I'm going to draw this out so that we can take a look at the anatomy of the model. And what we'll find is that we have uterine horns, that's 2, and these little knots at the top, those are the ovaries. So you've got ovarian pedicle there. And then the ovarian or the uterine horns combine into a uterine body, and another knot at the base would represent your cervix. So at this point, I'm going to go ahead and start doing some clamping and ligating and start to hopefully sterilize this animal. And so I'm going to do the first ovarian pedicle. I'm going to do a 3-clamp technique, and so that means all 3 clamps are going to be on the ovarian pedicle. Because I'm working with an assistant, I'm going to choose to put the rings towards her. If I was working by myself, I would probably choose to put the rings of the forceps towards myself, since I would be the one opening and closing them. It doesn't matter if you place them from proximal to distal or distal to proximal, as long as the spacing is good, and that spacing is about 5 millimeters apart. If we put them farther apart than that, our ligatures end up farther apart, and then we get more necrotic area after the ligatures. One note on proximal and distal. Once we get into abdomen, the way we look at proximal and distal is basically where the blood supply comes from. So in this case, the ovarian artery is carrying the blood supply out of our patient to the ovary. So the proximal would be closer to the body and distal would be closer to the ovary. Once we switch down to the uterine body, paired uterine arteries are now bringing blood supply along the uterus. And so at this point, proximal would be closer to the cervix and distal would be closer to the uterine bifurcation. So you'll hear me use those terms as we go along. So our 3-clamp technique, you'll see I have a combination of straight and curved clamps. If that's the case, I'm going to choose to place my straight clamps distally and my curved clamps proximally. And the reason I'm going to do that is so that the curves don't face each other and kind of run into the clamp next to it. And once I have 3 clamps on the ovarian pedicle, I'm going to turn these to the side so you can see that if I were to put the curved clamps underneath or proximal to the straight clamp, you can see how the tips would just kind of run into it and I wouldn't have space to work. So that's why I said use the straight one and then the curved ones. As far as suture, we have a lot of options to use, but for the sake of the LMUterus practice and exams, we're going to have you use PGA. This is a generic version of Vicryl. It is a multi-filament absorbable suture. When you draw the suture out of the packet, make sure you're doing that with the needle drivers because the needle is uncontrolled at that point. You don't want to poke it into your glove. And then as you pull that out, make sure you're not doing a big suture launch, so be a little bit controlled about it. We want to keep it within our sterile field so that we don't have to go ahead and get another one right away. And then for the very first ligature that you're going to place, I'd like you to demonstrate a hand tie. And so I'm going to go ahead and gather up my suture for that. And so I don't need my needle because I'm going and doing a circumferential ligature. I'm going to put my needle drivers back down. And the reason I'm doing that is so I don't accidentally use them because it wouldn't be a hand tie anymore. And as far as the suture gathering, you could choose to put the needle at the base of the palm, and that means, again, not 10 centimeters down where it can dangle and catch on things, and definitely not within my palm because then if I close my hand, I'm going to puncture my glove. The other option is that you can put the needle in between your index finger and your thumb. Either way, you're going to gather your suture preferably in 1 or 2 gentle loops so that you don't excessively kind of build too many loops and then have them all get turned into a knot. So whenever I have that, I'm going to reach around the clamps and then I'm going to go ahead and do my hand tie. And so the first ligature I'm going to place is in the crush of the proximal clamp, and in that case that's the straight one. And so what I'm going to do is go ahead and cross and rotate through to do my hand tie. And with the PGA, which has a slippery coating on it, the reason is because it's a multi-filament that helps it slide through the tissue a little bit better. But because of the slippery coating combined with the latex here, a square knot is probably not going to be adequate for the PGA. And so what I'm going to do is choose to do a surgeon's here. And so you'll see throughout as I'm using this PGA, I'm going to be choosing to use surgeon's and miller's knots. Thankfully, when we get the PGA in a live animal and it gets moist from pulling through the tissue, it handles a little bit better. I'm going to ask my assistant to please remove the proximal clamp, and then I'm going to pull that surgeon's throw down into that proximal crush. And then I'm going to follow it up with 3 square throws, being very careful with each throw not to pull up the previous throw that's underneath. And then I'm going to do 4 throws on this. If I were to place a half hitch, I would be certain to tie an additional full square knot on top of it. So I'm going to watch as those come down, and then I'm going to have my assistant cut at 2 to 3 millimeters. Good. And so that's short enough that I'm not going to create a lot of extra foreign body reaction in my patient, but hopefully it's long enough that my suture's not going to unravel. So at this point, all the rest of the sutures I can go ahead and demonstrate as an instrument tie. Hopefully I have gone and done my hand tie adequately and everyone's concluded I can complete that. And then go ahead and set these back down. And so my second ligature is going to be in between the first ligature and the middle clamp, being sure to demonstrate flashing of the middle clamp as I'm tightening. And so I have 2 options on doing these first throws. I can either put the drivers in the center and go ahead and wrap twice and grab the end of my suture and pull that over, and that'll create a surgeon's throw. The other option I have is I can form that very first throw over top of my finger, and that helps to stabilize things. I don't mind which one you choose to do as long as you do it well. And then as I'm tightening this, I'm going to ask her to flash the middle clamp, please, and that means to open but not remove. I'm going to pull tight, and then I'm going to ask her to close that clamp, please, and then I'm going to go ahead and put my next 3 throws on. Again, being careful to get good knot quality and nice square throws and strong ligatures. So at this point, I think that I've tied off this ovarian pedicle adequately, and so at this point I'm ready to cut. I can choose to use scissors or a blade to cut with. If I choose to use scissors, fairly straightforward, I'm going to cut in between the 2 clamps. One clamp will stay with my ovarian pedicle, one will go with my uterine horn. The other option I have is to use a blade. Because that's a little bit more challenging, I'm going to go ahead and demonstrate that. My preference is to take the clamps back from my assistant at this point so that I can put under very slight tension the section of the pedicle in between the 2 clamps. It helps to facilitate the cut. And then you'll see that I'm facing the blade away from my patient. I'm not cutting down towards them and away from myself. That way no accidents are going to happen here. And then I go ahead and cut in between the 2 clamps. And so I'm going to take now the uterine horn and I'm just going to kind of gently reflect it caudally. And now I'm interested in what's going on with this ovarian pedicle. And so I can either have my assistant hold that clamp or I can, but in either case, I'm going to want to grasp the pedicle. And that way I can check for bleeding. So my assistant's going to remove, please, that clamp. I'm going to check for bleeding, and finding none, I'm going to go ahead and gently return it into the abdomen. At this point, I'm going to follow the first uterine horn down to the uterine bifurcation, back up the second uterine horn to the second ovary. On this ovary, I'm going to demonstrate a modified 3-clamp technique, and this may be used when we perhaps don't have enough space for 3 clamps on the uterine pedicle because it's too tight. And again, I'm going to start with my straight clamps if I'm using a combination of straight and curved. And so I'm going to place 2 of my clamps on the ovarian pedicle. And I'm going to place the 3rd clamp distal to the ovary, so in other words between the ovary and the uterine horn. This is the area where the proper ligament would be, and that proper ligament, if we were going to break down a suspensory ligament in, for example, our dog or our cat, we might choose to place this clamp before we ever place the others. And the reason is because if I have this proper ligament clamp in place, I can choose to palm it, go ahead and break the suspensory ligament. LMUterus doesn't have a suspensory ligament, so I don't have to worry about doing that. But it's one thing to note about that proper ligament clamp is that you may already have that on there because of breaking the suspensory ligament. So on this pedicle, I'm again going to go back to my PGA. I'm going to make sure that I have my suture gathered, and I'm going to place a first ligature in the crush of the proximal clamp. So I'm going to pass that suture around. In this case, I'm going to demonstrate a Miller's knot, and so I'm going to pass that suture around a second time. And I'm going to be careful that I don't lose the X that I've created across my index finger, because otherwise I have to start over again. And so as I bring that extra piece up through the center, I form an asterisk. I reach under one side, I grab the end and pull it out, and now I'm ready to pull down this sort of messy little Miller's throw. And I'm going to have my assistant please remove the proximal clamp, and I'm going to pull down that Miller's throw into the proximal crush. And you'll see that the loops are tightening a little bit unevenly, and when that happens, sometimes I may have to pull on one side and then the other to get those to reduce down nicely. It should have a lot of crushing power to this knot, so it's one that we commonly use where we have maybe a larger pedicle or something we're a little bit more concerned about ligating. And then I'm going to put 3 square throws on top of it to complete my secure ligature. Have my assistant cut it 2 to 3 millimeters, a little shorter. So for the sake of the exam, I'm going to skip placing a second ligature because it's very much more of the same. If this were a live patient, I probably would choose to place it, just feeling that it doesn't take very long to do, and yet it does protect my patient's safety. At this point, I'm going to take the clamps back from my assistant, and I'm going to choose to cut proximal to the ovary. This part's important. If I cut on the other side, I leave the ovary in, and then I have ovarian remnant syndrome, which I want to avoid. And so I'm going to cut right along that proximal clamp and make sure that all of the ovary is removed with the reproductive tract. Do you mind holding that? I'm again going to check for bleeding. Can you release the clamp, please? And finding none, go ahead and return the pedicle to the body. So at this point, I'm going to go ahead and follow the uterine horns to the uterine body and down to the cervix and find the cervix. Here we go. And I'm going to go ahead and do a 3-clamp technique. Now you'll notice that I've reflected the reproductive tract caudally, and the reason that I've chosen to do that is because it slightly stretches the area that I need to tie off. It makes visualization a little bit easier. So I'm going to place my first clamp within 5 millimeters of the cervix. So in other words, not way down here, but here. And you'll notice as I'm clamping that I am not just in the tips of the clamp. So in other words, the clamp does go all the way across what it is that I'm tying off, but I'm not all the way down to the box locks here. So somewhere in between the two. So all the way across, but not kind of choked down all the way to box locks on these. And then my clamps are going to be within 5 millimeters apart. And I'm going to have that assistant kind of reflect them caudally. It makes my job a little bit easier. So for my first ligature, I'm going to do one more circumferential ligature. I'm going to choose to do, in this case, a surgeon's because of ease. You could do a Miller's if you chose to. And I'm going to go ahead and wrap around and ask my assistant to remove that proximal clamp. Go ahead. And then I'm going to pull that throw down in the crush for much more of the same that we've been doing. And I'm placing that circumferential ligature first. Before I place the second ligature, which I'm going to do a transfixing ligature for. And the reason that I'm doing that is because a transfixing ligature is going to require me to put a needle through some of the tissue. And so if I've not already had this ligature and the blood supply comes up here and I happen to hit a vessel, then I can have some bleeding. Now it's probably not really a problem for my patient, but a little bit is for me getting a bit worried about what's going on. So particularly for a novice, it's kind of a bit distracting when you have more blood in your field than you need to. So I'm going to go ahead and lock the needle in my drivers. And there's a couple different ways to do a transfixing ligature. I could take a bite down away from me, or I can bite from caudal to cranial. Usually I'll choose to take the clamps from my assistant. That way I can more carefully place my needle. And I'll kind of hold the reproductive tract upright while I take a bite from caudal to cranial. The reason I do that is because it's a bite away from the patient. Well, why is that important? Well, because I've seen lots of people stab their patients in the process of creating this bite, and I really want to avoid that. So you'll see that when I go ahead and create this little portion that's embedded in the reproductive tract, that this piece is on the side that's near me, and that's fine. I'm going to go ahead and choose to wrap my needle end around what it is that I'm tying off, so that then when I tie the main portion of this knot, the part that goes all the way around the reproductive tract, that I can kind of guide that knot so that it's on the side opposite me and it's not laying right on top of the one on my near side. On this side, I'm going to need to do my surgeon's throw. And for the sake of this knot, this is going to count as my first throw, and I'm going to have my assistant please open, but don't remove. That would be to flash that middle clamp. And I'm going to make sure that this ligature ends up in a separate place than my first ligature. I don't want them on top of each other. And so if I need to, I may have her move that clamp a little bit farther down, but I do want to make sure that those are two distinct ligatures. And then I'm going to have you close, please, that middle clamp. And so now I have 3 more throws to make this a secure ligature. And again, that knot is ending up, roughly speaking, on the far side of the table from me because that initial bite was on the near side. Once I've placed those 2 ligatures, it's kind of more of the same. I'm going to go ahead and take the clamps back from my assistant. I'm going to cut in between 2 clamps, away from my patient, away from myself. And then I'm going to go ahead and remove the reproductive tract from the picture. And once again, grasp the stump. Have you released the clamp, please? Check for bleeding and gently return into the abdomen. So at this point, I've completed the spay portion and I'm ready to go on to closure, equally important. I'm going to switch over to PDO. This is the generic version of PDS. It is a monofilament absorbable suture. It may or may not be what you would choose to use in your live patients, but it does work nicely to close on the models. And then again, I'm going to go ahead and grasp the needle out of the packet using the drivers, and I'm going to lock the drivers about 1/2 to 2/3 the way down the curvature of the needle. And I'm going to bring the suture out in a controlled manner so it doesn't go outside my sterile field. You'll notice that PDO has memory. Some people find that a little bit annoying. As long as you keep it within your sterile field, it's okay that it kind of lays there. Some people may choose to kind of tuck it behind a finger, but if you really are annoyed by the memory, you can go ahead and stretch the suture out one time, and that helps to limit the memory. So you'll see that it'll bounce back, but it won't be quite as tight. Personally, since it keeps its memory anyway, I just kind of go with it. It'll probably bother you less and less with time. So in my live animal, if I was on the linea alba, I would just be suturing the holding layer only, which would be linea alba if it was wide enough. But because I need a 5mm bite back from that cut edge, it probably means that I would be back into this kind of situation. And so when I'm here, the holding layer of the abdominal wall is the external rectus sheath or external rectus fascia. And so in my live patient, I would be isolating that and just suturing that. In the model, we don't really have an external rectus fascia, and so we're going to have you demonstrate suturing the abdominal wall full thickness. The reason we would not do that in our live patient is that it doesn't add to the security of the closure, but it does add significantly to post-op pain. So that's one difference to keep in mind. So I'm going to bring my needle back from the cut edge about 5mm and then pass the needle and the suture through and then retrieve my needle. And you'll see that I held on with my thumb forceps until I have my needle back. So if you let go with your thumb forceps too quickly before you retrieve your needle, it makes retrieving your needle very difficult. You tend to lose your needle. I'm going to come on the near side and go a nice 5mm bite back from the cut edge and retrieve my needle. Time to go ahead and gather. And once I've gathered my suture, then I can go ahead and tie my first body wall ligature. And in this case, unless you have a lot of tension on closure, which you shouldn't in the LMUterus after completing the spay, you should be able to just use square throws and have this ligature come adequately tight. So again, 2 to 3mm is where we're going to cut the sutures. And as you're having your assistant cut sutures, it's important to make sure that you hold the suture so that they can see the suture and where it is. So it's no good if you can see where 2 to 3mm is, but you're holding the suture away from where they can see it in their line of sight. So that's something to consider. And then we're going to place 2 of these body wall sutures for the sake of our assessment, and we're going to do that 5mm apart. So I'm again going to grasp across the cut edge. I'm going to come 5mm down. I'm going to do another 5mm bite back from the cut edge. I'm going to draw my needle up, regrasp, and every time I'm going through tissue, I'm locking my needle drivers. That prevents the needle from wobbling in the tissue. So you can see on this side, I started to bring the needle up a little bit too deep, and so it started to come through some of that subcu tissue, which I would rather that I just isolate the body wall or in the live patient external rectus fascia. So I'm just going to back my needle up slightly and then bring it back through, just having caught that body wall and not having caught that subcu. If I waited until I had already pulled it through the tissue, at that point there's not anything I can do. I can't send the needle back through the tissue and undo it. So it's important to watch where the needle comes out as you're working. It's important in your live patients to make sure that you go all the way within 5mm of the end and the start of your incision. But for the sake of the exam and the sake of time, we're just going to place 2 that do need to be 5mm apart so that we know how to do the spacing. And then we're going to suture just a small segment of subcutaneous, and so I'm going to do a simple continuous pattern demonstrating buried knots. And the way that I'm going to start that is on my near side. I need to create a deep end to tie to. And so I'm going to go ahead and grab some subcu, making sure that I'm including that mesh layer, but that I'm not including skin and not including body wall. And so I've chosen to do a deep to superficial bite here, and I take the tail end of the suture and I point it towards the middle of the incision. That's going to help me when it comes time to tie here in a minute. And then I come on the side opposite me and I go from superficial to deep, again making sure that I get some of that mesh in the suture, and that's going to keep it from pulling through. The foam isn't as strong as the mesh is, and so you potentially can have it pull through if you don't incorporate that layer. So once I have these both deep, and you'll see they're both pointed towards midline, so in other words there's not one pointed towards the middle and one coming out in this little triangle, I'm going to go ahead and tie here, and because I'm trying to get this knot to bury, I'm going to choose to pull parallel with my incision as opposed to perpendicular like I did for my body wall. You'll see that my hands have to cross in the process of pulling parallel. That's normal. That's what should happen. And then I'm going to hold up just one end for my assistant to cut. If I hold up both ends, it communicates, hey, I want you to cut both of these. And so I'm going to just hold up one end and preserve the other one so that there's no mistake made. For the sake of the assessment, if you tied this correctly, I'm going to say that it buried. And then in order to keep it buried, I want to do one more half bite. On my near side, I'm going to go very close to my knot, deep to superficial. And what that's going to do is it's going to keep that knot nice and deep and prevent it from being pulled superficially right away. And then every bite that I take from here is going to be on the far side, superficial to deep, on the near side, deep to superficial. If you can come all the way across in one bite, that's fine. If you can't and you need to come up in the center the way I demonstrated with the body wall, that's fine too. In general, if you are going to come up in the center, I want you to not go ahead and go through the process of gathering your suture. In other words, needle to the palm or in between the fingers, gather the loop, that kind of thing in between. So I only want you to do that when you're planning on tying. Otherwise, this takes up a little bit of time and it costs you in terms of efficiency. So I'm going to want to take one more general bite so you get the idea. So again, on my far side, I'm going to go superficial to deep, deep to superficial on my near side, making sure that I catch some of the foam and the mesh. In my live patient, I probably would be handling just the sub-Q layer, but you'll see I handled the skin just a little bit. Because of the way the foam doesn't handle very nicely in the model, we allow that. But please be careful that you're gentle with it and you're not kind of peeling the layers back off of each other, because that would not be an appropriate use of your thumb forceps. So at whatever point I feel like I'm ready to go ahead and finish my suture line, I'm going to create a deep loop. And the way that I'm going to choose to do that is by going superficial to deep on the opposite side and drawing my needle up. And then this loop is a superficial loop, and I want to get rid of it as soon as possible because otherwise I could be confused by it and try to tie to it later, so I just go ahead and pull that down. And then because this end is deep, this is the first part of my deep loop, I'm going to come on my near side and go deep to superficial, and this finishes building that deep loop. So in other words, right now I have a deep loop and a superficial end, which is getting me closer to what I need. But I still need this end to be deep. And so one more time, I'm going to come on the side opposite me, superficial to deep. And so this is a pattern that you can either memorize or you can logic through. Either is fine. You will notice that as I've done this pattern, I have not backhanded my needle. In other words, every time I'm taking these bites, the needle point is facing towards me, and that can help you to logic through this pattern if you choose to. If you find yourself taking bites away from you, that may be a sign that you're on the wrong track and want to reassess what you're doing. I'm going to pull suture down and go ahead and tie to this loop, being careful not to get half hitches. Now, what we want in the sub-Q is gentle apposition. It doesn't need to be very tight, but it does need to oppose the tissue. So you'll see as I went ahead and sutured this, I pulled adequately tight so that I'm not looking down and seeing body wall. If I were looking down and seeing body wall, I would need to be careful about maybe tightening up this loop a little bit right before I tied. Now you will see body wall just in this very last square, and that's normal. Once I tighten this last loop, that will go away. When I go ahead and tie to a loop, I need to be especially careful that I'm not half hitching because it is a little bit more challenging. And so as I come through this loop, I'm going to open my needle driver ends, and that helps to even up those two sides of the loop. And you'll see that I am getting good apposition. So that little piece closed up, I'm not seeing body wall underneath. If I was still seeing body wall underneath, I would grab each side of this loop and give it just a little tug and make sure everything came nice and snug. The better solution is to keep it nice and tidy and neat as you go along, but if that didn't happen, then now's a good time to take care of it. Again, I'm pulling parallel because I want this knot to bury, and I'm going to tie my 4 throws. It's got a little bit of bulk in it because of tying to the loop, but if you demonstrated the appropriate throws, I'm going to consider it as buried. We're going to go ahead and cut at 2 to 3 millimeters. Okay. So now I'm going to go ahead and do my intradermal. And so my intradermal pattern is a skin closure, but it's not an external skin suture. And so for that reason, I'm not going to go back and take them out, so I need to use an absorbable suture. So in this case, I'm going to continue on and go ahead and use my PDO. And so this is very much the same in terms of starting and finishing, because it does involve buried knots. And so when I go ahead and start, I'm going to do a deep to superficial bite on my near side, in through the sub-Q and out through the cut edge of the skin. I don't want to come out through the top of the skin, because then it's no longer intradermal, it's coming out the top of the skin. And the goal is not to have that suture coming out the top of the skin and not giving the animal anything to chew on. I'm going to point the tail end of the suture towards the middle of the patient again, and take a superficial to deep bite on my side opposite, again with that deep bite coming out within the foam layer or within your sub-Q layer, and that's going to help my knot to bury. I'm going to gather my suture and I'm ready to go ahead and tie. And again, because I want this to bury, I am going to pull parallel, and hopefully that will help my knot to bury in between my tissue layers. On buried knots in particular, I don't want to be adding throws, so I'm going to watch on these especially that I'm not throwing half hitches and having to add throws, because it does add bulk. I'm going to have my assistant go ahead and cut again 2 to 3. And then I'm ready to go ahead and start my pattern. Now where in the sub-Q, I was basically spiraling through the tissue, in other words, the needle was pointing towards me. In this case, for the intradermal, my needle's pointing down parallel to the incision. And so my very first bite, I'm going to go very close to this knot, because it helps it to bury, it helps it to pull the skin over top of it, and I'm going to go in and out through the cut edge, a nice small little bite. The reason I say a nice small little bite is because my next bite, I'm going to come back just a tiny bit and again pull the skin over top of that knot. It doesn't matter if I started the bite on my near side or on the far side, as long as I'm accomplishing what I need to in terms of skin closure. So this is the only bite where I usually will go back just a tiny bit, and again, that'll help to pull the skin closed over my knot quite nicely. So I'm going to do about 2 more bites, and then I'm going to go through burying the knot again so that this pattern will be finished. So in and out through my cut edge, and at this point I'm just going directly across, and so when I look down I should see that coming directly across. If I start going down the incision farther, then I start to get gaps in the incision. If I go backwards in the incision, then I'm taking more bites than I need to, and I'm prolonging my surgical time, adding more suture, those sorts of things. So some of the time you'll definitely want to practice closing the entire line, and I say that because a lot of people will get too deep in the end and they won't have enough room to bury their knot. And if you always just quit early, you'll never find out how much room to leave. But for the sake of your exam, you only need to place a small section. And whenever you're done placing that section, then I'm going to go ahead and bury the knot, and I'm going to do that by taking a superficial to deep bite, and again the deep part's going to come out through the sub-Q. And this should all start sounding a little bit familiar at this point. A deep to superficial bite. You'll see I pulled down that loop. That was a superficial loop. I want to get rid of it as soon as possible so that I don't accidentally tie to it. On the other hand, this is my deep loop, so I want to keep this one up. And then I'm going to go ahead and take one last bite. And this is my superficial to deep bite. And I'm going to bring the needle up next to the loop. And so this is another area where people can go wrong. And so you'll see as I'm pulling this last piece down, this last superficial piece, that it's coming sort of towards the end of the incision, and my deep loop and my deep end are close to each other. So there's one of the professors that says, well, this is 2 elephant ears and a trunk in the middle, and you can kind of see the elephant ears and its little trunk. It's fine if you want to think about it that way. The other way you can think about it is before you tie, you ask yourself 3 questions. So is it a deep loop? The answer should be yes. Is it a deep end? Yes. And are they immediately adjacent to each other with nothing in between? If the answer to all of those is yes, then your knot is going to bury. If it's no, then you need to fix those things before you try to bury a knot. So I could go ahead and tie the same knot in terms of square throws that I chose to tie in my sub-Q layer, and that would be fine. It does create a knot with a fair bit of bulk, which would be a challenge then to bury. So I'm going to show you a different knot that we'd like you to tie at the end of your intradermal that decreases the bulk of the knot and will help your knots to bury a little bit better. And it's called an Aberdeen. And so for the Aberdeen, we don't need our needle drivers, so I'm going to get rid of those. And then what I'm going to do is I'm going to take this loop and snug down the skin so that the skin is well opposed. And then I'm going to reach through the loop and I'm going to take that piece of the working end, or the needle end, through it. And then I'm going to pull that loop down, keeping hold of my new loop. So that's one. Then I'm going to reach through again and take that needle end and I'm going to create another loop and pull that one down, nice and snug, again keeping that skin well opposed. That's two. And the trick here is making sure the skin stays opposed with each one. And then I'm going to reach through, I'm going to take that end, pull it through in another loop, and pull that down nice and snug. That's three. And four. And what this does is it creates a bit of a smaller knot than what I would have otherwise. So once I've done my four, then I reach through one more time, and this time I'm going to draw the entire needle end through so that I finish my knot. And I'm going to pull that loop down. And so that's, some people call that a 4+1 Aberdeen, but that's an Aberdeen knot. And then at this point, I could either have my assistant go ahead and cut at the skin edge, and you can see that knot actually buried quite nicely given the size of the suture and the thin skin of the model. And people will choose that knot over the squares because it does tend to bury a little better. Or I could choose to do what's called smurfing the end. So if the knot was sticking up and I wanted to try to flip it upside down, what I can do is I can take my drivers and lock them. I can come along behind the knot, and by behind the knot I mean down the incision towards where I started. And then I'm going to go deep to that knot, and I'm going to bring the needle up about 1 centimeter down the incision and out through the cut edge. And so where that would be is past the end of the incision here, but because I went short, I can't actually get to that portion of the incision, but it is in the same line as the incision. And then I'm going to go ahead and give it a sharp little tug that flips my knot upside down. Oh wow, that looks really nice. It went away. It makes me happy as a surgeon. We're going to go ahead and cut the end level with the skin, and that's my skin closure. So again, this is how we're going to go through and learn the skills that you would use in a spay and demonstrate them on the LMUterus. This is not a recipe for a dog spay or a cat spay. It is a recipe, however, for an LMUterus spay, and so that's what we're going to have you use it as. Thanks.